I want to welcome everyone today. My name is Trisha Franklin. I'm with the Rural Health Transformation Program as a program coordinator, and I want to welcome you to this RHTP Impact session. On behalf of the Department of Health, Commissioner Heidi Hedberg, who is speaking today at the Pathways to Recovery Conference, and Deputy Commissioner Emily Ricci. Welcome to these sessions. We hope you find them helpful and useful in participating. And for those that weren't able to make it, they will be recorded. So without further ado, let's go to the next slide. And I want to welcome our speakers today. Our topic, let's do our topic first, healthcare access. And then next slide, please. We'll do some reminders on what these sessions are for, what our goals are, how we want to expand access to care in Alaska with our RHTP funding, and go through some breakout discussions to talk a little bit more about how things are going in your communities, and then we can wrap up. Next slide, please. I want to introduce our speakers. We have Dr. Ian Zink. She's an emergency medicine physician with ZinkWise Consulting, and Dr. Lisa Rabinowitz, emergency medicine physician at RABZ Partners. Take it away. Thank you.
Awesome. Thanks so much, Trisha. Thanks for kicking it off. I think one of the things that I just always admire about the team at the state is it's a deep team doing amazing work, and Trisha's behind the scenes keeping it and here kicking us off today. So if you go over to the next slide, we'll talk a little bit about why we're here and what we're hoping to get out of today. If you've been on these before, please put in the chat box who you are, so your name, your organization, how you're affiliated, but then also like how your organization is really thinking about how to move upstream. How do we increase healthcare access? So is that, mobile integrated teams? Is that increasing specialty service? Like, how are you thinking about how do you increase healthcare access across the state as a whole? If you go on to the next slide, just a few little grounding slides for you as a whole. Here is where we're at today. We are at the Impact Series. So we have had the opportunity to have 3 regional planning meetings, many more coming up. So it's been great to be in region. Personally, been bummed I couldn't make it, but others have been able to be there, and I've heard great stories and perspectives. There's also office hours and the website, but this is really a dialogue more topic specific where we're bringing in different people who are experts in the field. And we have a great speaker here today sharing ideas that are happening both in the state of Alaska and from other places to really kind of focus in on a specific topic to create connection and solutions to have a real impact with these dollars on thinking about the health and well-being of Alaskans. Moving on to the next slide. Nice job on the chat box, everyone, putting stuff in. This really fits within Alaska's goals for this initiative. So as you all know, a 5-year initiative, every year kind of reevaluate and move forward, but it's got to meet within these 3 major goals. And today we're really thinking about that goal 1, promoting lifelong health and well-being for rural, remote, and frontier Alaska, and particularly thinking about how we increase healthcare access across our state as a whole. Moving on to the next slide. These sessions are some things and they're not some things. So really, Dr. Rabinowitz and I are not a part of the LOI process. They're not a technical assistance forum. They're also not an opportunity for just people to kind of promote their idea. They're really an idea to like collaborate and think about how all of our ideas can blend together and be able to listen loudly to each other to create a forum for coordination and improving health. So this is really a coordination series, both with those in Alaska and outside of Alaska, and an idea behind them has been really an interactive forum. So those of you who've attended this week's for other sessions will be breaking out into break rooms later on today so that you get a chance to talk to each other, not just hear from us, and be able to connect, and a mechanism to foster partnership and coordination amongst you all, the most important people on this call, the participants. So with that, we're going to go ahead and switch to the next slide, and Dr. Rabinowitz is going to dive into the data.
Perfect. So welcome, everybody. We're going to look just a little bit at our data across the state currently and where we're at with access to specialty care. We know that rural Alaska has limitations to specialty care. That's to be expected. A state with our size, our workforce, our population, we're not imagining that we would need all these specialties in rural Alaska. What we need is access to specialty care, both for the clinical teams and the patients. So when that care is needed, when that expertise is needed, it is available. And so currently, as we look on this statewide, we are below the national average for physicians. But a bulk of our work in our state, which is no surprise, is being done by our primary care providers, our advanced practice clinicians, our PAs, our nurse practitioners. We also have higher than national averages of dental care. And we know dental care is important to our overall health. As we dive into the right side of the screen, we can definitely see that we are below the national averages on some of our specialty care. Pediatrics, general peds, and also psychiatry comes up a lot. Psychiatry for adult. We've also had, OBGYN we talked about yesterday, and a lot of the internal medicine subspecialties and surgical care. And next slide. So Alaska also has limited intermediate care facilities. So this limits some of our in and out of hospital care as that expertise and specialty care is needed. We've also got critical areas, pediatric neurology and rheumatology, where we don't have access to that currently. There are also no acute dialysis centers off the road system, so that becomes a challenge for those patients with long-term kidney disease. And next slide. So we know that our state is vast. We talk about that a lot, but the average number of miles is 150 that Alaskans travel to get access to care. That's a long ways. It stacks up when you're feeling sick, when you have to get a ride, when you're limited in terms of leaving your support network behind. And a quarter of Alaskans did relay that their location and access did prevent or delay access to care. And at least half of Alaskans have reported delays in care and long time for appointments. So even though on a chart you may see that we have great, pediatric psychiatry in one community, if you can't get in for 8 to 12 months, it's still a barrier to care. So we need to take that in mind as we look at the data. We only have one NICU and one standalone psychiatric hospital, which also limits that. There are things that we don't have in state, things like a dedicated burn center, organ transplant. Patients have to go out of state for that. And that's probably appropriate at this time for our state. And so it's not, again, that we're advocating that all specialty care is in Alaska, but we need to make sure that we're thinking strategically about how we position specialty care and how patients can access it. And next slide. We're going to give you a sneak peek to our speaker today. You probably saw some cardiology data on one of our slides, but we wanted to point out that in addition to other specialties, cardiology is lower than our national averages for amount of cardiologists in our vast state. We still have favorable outcomes in terms of cardiovascular disease, but there's always room to improve. We also see some of our other leading causes of death. We looked at this yesterday if you were on the call. And many of these are chronic diseases that require subspecialty care or expertise. So just wanted to highlight that as we move ahead. We're going to move on to the next slide, and I'll turn it back to Dr. Zink.
And I get the distinct pleasure to welcoming Dr. Linda Ireland to being able to share her perspective. It's been great to have her on many of the calls. It's been fun to see her all sorts of different places and thinking about the rural health transformation, but more importantly, serving Alaskans for a long time across a huge scope and breadth, and thinking about the ways that specialty care has been delivered across the state of Alaska. So kind heart, dedicated cardiologist, and active member in trying to make our community and our system better. Dr. Ireland, over to you.
Thank you so much for those kind words, Anne, and thank you, Lisa, for both inviting me. I think it's a super exciting time for all of us to come together, for the ability to kind of put some money to prevention and where we can do some really cool things in Alaska. I was asked just to kind of talk a little bit about what I've done with CPR training across the state of Alaska. So as 2 years ago, as a part of the American College of Cardiology leadership, we were tasked to kind of come up with projects for the state, for our governor. And what we ended up coming up with is community prevention, cardiovascular care. How do you get word out to community, both in the city and more remote? And we had to kind of, it was so vast. We were thinking about food as medicine. We were thinking about obesity and all these other things. But what kind of percolated to the top is Alaska is still one of those communities that in states that do not have CPR mandated in high school yet. So we decided to say, okay, well, let's put that to the top of the list to see what we can do to help Senate Bill 20, which was on the docket for going through for CPR in schools. So it was kind of pressing for the time. So we tried to get into the schools. It was a little bit difficult, mostly because of networking and ability to try to get in at the right time. So we reached out to the local Boys and Girls Club here in Anchorage. And for those of you who are not aware who live in Alaska, there's a vast number of Boys and Girls Club that we used to have that spanned the entire state, from Nome to Kotzebue to Ukqiavik to Sandpoint. And it was a great entry point. So what we decided to do first is do a proof of concept in Anchorage and Mat-Su, where we were able to go to the local Boys and Girls Club leadership and promote CPR training in youth. So we even went younger than high school. We went kind of, age 6 to 12. And we did it on, kind of superhero stuffed animals. And it really worked out well. The kids were enthusiastic. We went to all 7 clubs here in Anchorage and Mat-Su. We got a local news piece that kind of caused us to raise up our game a little bit. So then we applied for the ACC grant, which we were awarded a grant. And then we were able to then take that to other places more remote in Alaska. And how do we decide where to go and how to get there? So what we decided to do is go again with the Boys and Girls Clubs, because that was our entry level. I think having an entry level to go to the more remote areas is important. So we then, I think the ACC has this thing called a health equity heat map. So you actually can look at the social vulnerability index in these local areas that had Boys and Girls Club and cross it over with the heart disease index, and it turns different colors. So there were dark purple areas. So we were able to concentrate on Kotzebue and Nome, where the Kotzebue, the social vulnerability index was over 95, mostly due to housing and transportation issues. So as we went to teach CPR at these places, what we also wanted to do was bring cardiovascular education to adults. So I think trying to figure out how to dovetail that was where the rubber kind of really met the road. What we didn't realize is how difficult it was going to be and how much time it was going to take to be able to establish the relationships remotely, make sure that what we were doing was, socially correct in the places where we were going, that we had local leadership beyond the Boys and Girls Club. So we had to reach out to the community center at Nome, where we did the education with the adults and blood pressure cuffs and AEDs, along with the hospital at Kotzebue, with the local physicians, all targeted through ANMC. So we had a lot of partnerships that we had to kind of establish ahead of time that were allowing us to be able to go to Kotzebue and go to Nome. We did the CPR training in the morning, and in the evening we had kind of a lunch and learn, but a dinner and learn, where the community would come to the community centers, and then they would come to the local hospital where we had a booth with people coming in and out of the hospital. We gave out blood pressure cuffs to people who needed them. And then we got the CPR training going, which was a great success. But again, the barriers were just the time and trying to figure out what leadership was out there. And we had great success with being able to partner with ANMC and trying to figure out who the people were that were able to kind of help us. And then I think just circling all the way back is what we were able to do is with the video clips that we were able to get in the local news, we were able to then have an advocacy day back in Anchorage. And I think this is where it comes full circle, is what you do in these communities and all that stuff is coming full circle with the education. What we were able to do is meet with Senator Gray Jackson, who was the sponsor of Senate Bill 20. And then we had House Representative Gray come in and for the advocacy day. And he was able to say right then and there that he was interested in supporting a House bill, which coincided with the Senate bill the same day. So with all of that, we were able to kind of move that forward. So it was a very big understanding and a loop that happened with just trialing it locally, then going out to the more remote areas to do it, and then getting the support from everybody that came along with it. And I think really where we're all trying to go to is this more remote area, or what we can do for the whole state of Alaska rather than in Anchorage or rather than Mat-Su. It's just for everywhere. I think understanding the importance of creating relationships, and then the ongoing support that you can get and what can happen when you actually have boots on the ground somewhere, and establish relationships that are there, and that will continue to come. We just got asked from Nome to come back to the Boys and Girls Club again to do that again. So we're excited about that, and I think I think there's more data that you can have. And I know, Anne, just as a kudo to you, I've been looking at all that pop hive data that you have, and I think understanding the obesity and all those things that are trackable now, I think with primordial prevention, which is kind of a hot topic and a great interest in me, what we can actually do, not only just doing it, but then tracking it, tracking it and tracking what we can potentially do with whatever we come up with and these type of things, tracking it with what the obesity and the activity levels that you can actually track sort of real time. So that was my experience just in this short time over the past year and a half with the ACC grant, and I'm super excited to be able to share that with you guys, and I appreciate the time.
Yeah, no, thank you so much for sharing that. As you've been on a lot of these sessions, I think about those who don't know Alaska but have great ideas and trying to figure out. I mean, Alaska, you've been here a long time, and really highlighting how that relationship really matters, making sure it's culturally relevant really matters, how that can really take a lot of time and effort, but the real impacts that you can have when you kind of grow those relationships. I wanted to elevate that. I also thought, would you mind just spending just a minute or two kind of sharing, a little bit about like how Alaska Heart kind of thinks about how to provide cardiac specialty care across such a broad state? I know that you guys do a lot in that space, and maybe just a little bit kind of telehealth, rotating through things. I remember one time I was having a lot of palpitations, and you guys mailed me a Holter monitor during COVID, and then I was able to send it back in and do a remote visit. And granted, I could drive and I live on the road system, but it was a really great example for me on the way that you guys are thinking about telehealth and accessing specialty care.
Yeah, absolutely. So I think, with COVID, the one good thing, if you can think of anything really great that came out of that, is the ability for telemedicine to not only be reimbursed, but to actually be embraced. Because there's a lot of people that were just like, I don't want to do telemedicine, doesn't feel like doctoring. But I think what we were able to do is, especially for us in Alaska, we get a lot of patients shipped in for acute level care in the hospital, and then they go back to their remote villages, and it's a big disconnect in terms of being able to do follow-up visits with them. Kudos to A&MC, they do much more of the telemedicine, they have it dialed in. But what we're able to also do is to be able to have those telemedicine follow-ups, and instead of having the cost of coming back into town, which is an exorbitant amount of money for people, and then they're not with their family, and then there's the housing part of it. But the remote, actually, they love it. And of course, one of the big caveats to that is if they can have it, right? If they actually have the ability. But what I've told people is that even if you go to your local community center, there'll be internet and they've actually embraced that. It's like, okay, at least I don't have to travel in. I can still see my doctor over the phone. We've really embraced telemedicine follow-ups at the Heart Institute. We still do all the remote. We still send out the remote monitors for remote heart monitors for evaluation for arrhythmias. And, we're working on doing other type things, like even potential kind of like remote echo monitoring and stuff like we can do with the remote small echo probes that we're able to do. So I think just thinking outside the box on what we can do more remotely, is going to be more important in the future.
Awesome. So helpful. And I think for those who are coming and listening from the lower 48 and thinking about how can subspecialty care fit, where does it within the tribal system, not, just Dr. Island has a wealth of experience, and so does Alaska Heart. And I see other people on this call that do as well. Going over to the next slide, really refocusing us on like what these funds can be used for. They can be used a lot for this, as we've mentioned before, can't be used for broadband, but can be thinking about how do we invest in those telehealth capacities, thinking about how a system can potentially revamp itself to be able to think about how they can kind of embrace that. Certain technologies can be used as well. So you've kind of heard some specific examples, but also thinking about things that are culturally relevant, traditional healing capacities, pharmacy services and delivery, senior support support. We keep talking about transportation, and I just wanted to raise up like EMS, that care coordination, all of that really fits into this. How can we keep people in region, but also making sure that they have got the support and services that they need? So sometimes that is being able to provide services there rather than always moving the patient in home and community-based residents. So I just wanted to kind of highlight those. Dr. Ireland, just in reflection of this slide, anything else that you maybe want to raise up from your kind of lived experience in Alaska where you're like, man, I really hope funds are used for X, Y, or Z?
I think that it hits a lot of them. I do think the transportation is important, and I think the telemedicine communication is important, right? But I think also from a primary prevention standpoint, I think understanding that a need for a safe place to be able to go for activity is also a big highlight in terms of prevention.
Awesome. Dr. Rabinowitz, I know that you kind of wanted to also follow up on like retention and recruitment. I know this isn't the workforce one, but it also is important for accessing care. So, Dr. Rabinowitz?
Yeah, just in terms of kind of recruiting, retaining specialty care in Alaska, in terms of what you guys have done with your organization, Dr. Ireland, are there some things that you've found that worked well to increase kind of that specialty care up to Alaska, or things that you found as a big barrier?
Well, in terms of recruitment, we're in a recruitment crunch right now, so it's a really great time to ask, right? So I think the one of the big things about recruitment up here is just getting people to actually come up, right, first, and making sure that their significant other comes up and it's like, oh, we don't live in igloos, and we do have a road system, and we do have the ability to do culturally normal things, so to speak. But I also think that we're raising the level of what our APPs can do, right? And I think having those part of a dyad relationship with our care team has significantly improved how we deliver care with our advanced practitioners, both in the clinic and in the hospital. And I think they also work with the telemedicine. But in terms of recruitment, I think it's a difficult space right now because there's less cardiologists being trained in the pipeline right now, and we're having a lot of difficulty getting the people up here from a recruitment standpoint. Time off is important, right? To make sure you get time to go down to the lower 48 to see other parts of the families. But I think education and understanding what we offer, if we get them up here, we usually get them to stay.
Yeah, no, that's great. That one thing that on these regional meetings, we've been hearing a lot from the clinical teams in rural Alaska is that telehealth is great for their patients, but they're really wanting that telehealth connection with their subspecialty care partners. And so building that into a clinical process for them seems like something that we could definitely work on moving forward. So, especially the internal medicine residency, say in Soldotna that got started, they're trying to bridge that with subspecialists so they feel like they're supported and they can take care of their patients and not transfer as often as they had been previously. So I just wanted to highlight that again as something that we can think about today as we move forward. And back to you, Anne.
Awesome. Yeah, I just wanted to raise up two questions that had come in the chat bot, just to you, Dr. Ireland. So one, there's a question like, would a mobile room be helpful? Something that could be set up in an area that could have a lot of people be seen. Is it really kind of a structural thing that you see in challenges for being able to get people into a pre-scheduled kind of a place to be able to be seen? Or is it really more the staffing, getting out to regions? What would you say to like a pop-up mobile room clinic? Is that something that you feel like is needed from a cardiac standpoint?
Yeah, I think it's interesting. I think if they have internet capability with all of the phone platforms, we usually have the ability to do a pretty decent follow-up visit. But in terms of making sure that they have an adequate blood pressure and they can do all those things, and the medication list there are certain portion of the population that is very difficult to even just get on their phone and understand that telecommunication. So what I referred to it a little bit in the beginning, but we said just go to your local community center where somebody could help you. We tell them that in advance. I think advance discussion ahead of time before the appointment is important. Like, this is what you're going to need. Make sure all this is happening. There was like mobile carts, and there was like these. We originally thought of even in our remote areas, you can do like a telemed little room, like you're saying, where then it just is the staff that we kind of utilize from the primary care office or whatever. But I actually think that with the technology that's changing right now, I'm not sure how much that is needed unless it's something that has other diagnostic capabilities that we could utilize at the same time.
Yeah, it's fascinating how fast this all is changing. And that, with things changing, I know that insurance doesn't always keep up on a super fast speed. And you kind of talked about kind of the tribal system doing some really amazing work with telehealth. I know that you also spend a lot of time in the non-tribal system. And there was a question here about like insurance coverage. Is that a huge barrier still for you guys, or is it
It
not?
hasn't been, it hasn't really been. We've still adopted, it hasn't really changed that much, right? It's changed a little bit, it's ratcheted down a little bit, but for the most part, we're still getting reimbursed because it just passed it passed again in the state Senate and the Senate to be able to continue to utilize that. I think the biggest barrier for, in my opinion, for adopting something that's more permanent is it going to be there forever, right? Or is it going to all of a sudden be stripped away and telemedicine is not going to be covered? I think that's the biggest hindrance of creating a new, more sustainable platform that will be there for, as we practice going forward. Is the for a long time it was like, is that going to be stripped away and we're not going to be able to be reimbursed for telemedicine, right? And so with COVID that happened, and it was like a year at a time, right? It was 12 months and we'll reassess in 12 months, and it's hard to adopt something that's a more robust platform without knowing that it's going to be continual efforts to be able to still be reimbursable. But right now, that's not a hindrance to us. We're still doing all the telemedicine that we needed. I think the biggest slowdown is the other side of the ability to log on.
Perfect. No, I really appreciate your perspective on that. And there's some great questions about, residency positions, and I might actually push that one to our conversation that we'll be having on workforce, because we will be talking about rural forgiveness and who's kind of doing stuff in that space. And there's another conversation or comment, is there a strategy for rural medical clinics to learn from providers? So I guess this gets a little bit to like what Dr. Rabinowitz was saying. Like there's how do we make sure patients have what they need, but how do we also make sure that providers are able to kind of upskill and be able to have the space? Can you speak about how cardiology is thinking about that across the state?
Yeah, I thought a lot about, that was part of my ACC thing that just CPR trickled up, but just really how do you try to engage the community health leaders and all of those things that are different than physicians or even APPs that are delivering care, and trying to figure out models. And the ACC is working on a model to kind of have a playbook, so to speak, on when to ask questions. But from a Alaska Heart standpoint, we have a number that's called an office doc number where we're available for any questions that come in. And that's not proactive, right? That's as they're coming in, we answer questions. And when we're on call at night, any of the clinics can call us at night to ask us questions, because we have a provider on call for questions each night. But in terms of being proactive and going to the communities and having educational seminars and giving them toolkits, I don't think we've done that. And I think there's really a lot of room to grow to be able to be proactive in that area rather than reactive.
I love that. Something for us to think about. I'm going to go through the next slides quite quickly because I think Dr. Island provided a really great overview of like love what's been done here. But on this slide, this is a telehealth to improve, services, telepsych, telecardiology, telestroke. Dr. Island has highlighted a little bit what's happening currently with the cardiology perspective. And in the state of Alaska, telestroke and telepsychiatry are kind of slightly different points. But this is kind of a specific example with Alaskans to helping to improve access overall. Next slide. Here is an example of that I thought was really interesting in Washington State, thinking about how to address palliative care challenges. So it's 24 different organizations with kind of really thinking about how to get palliative care. I hear this from my patients a lot. Like, I don't want to be shipped into Anchorage to die. Like, I want to stay here near my family, near my culture, near my community. But people can get delirious and people can be in pain and people can have a lot of needs that can be really hard, particularly at the end of life. And so partnering with health systems, integrated palliative care, and offering telehealth consultation, as well as really moving towards like home-based solutions and remote monitoring to support people in community when patients really have a desire to spend their final days near community and culture. So I just wanted to highlight that one as well. And then moving on to the next slide. This is kind of a little bit along what Dr. Ireland was speaking about, like a digitally enabled rural hub and spoke model. So thinking about how can we really think about this kind of coordination, reliable pathways for rural care teams to access specialty care. So both being able to like make that call or being able to kind of have a telehealth, but then really investing in the modernization of EHR enhancement, cybersecurity, interoperability. This is how California is using some of its money, thinking about how to promote digital tools, remote patient monitoring, and to be able to have that connection. And then an additional layer on top of this on educating providers so that people feel comfortable in a rural community. Maybe they haven't really dealt with heart failure in the same sort of way, but having the skills and tools to know about like, okay, I can increase their Lasix and I can call them, or like this is when I know that I need to ask for help, because it may be outside of kind of their training or their expertise that they've had prior to being able to manage patients in community as a whole. So going on to the next slide, we're going to start to now break out into discussions. And so for this, I'm going to turn it over to Bryant to give us a lay of the land prior to us breaking out.
Thank you, Dr. Zink. Good afternoon, everyone, or good morning, everyone. So for the next 20 minutes or so, we're actually, and if you've been on these impact series this week, this will be familiar to you, but we're going to go into two breakout rooms, one led by Dr. Zink, one by Dr. Rabinowitz, and we're going to dive in deep on where we think we can have the greatest impact in regards to expanding access to specialty care. And we want you here to bring kind of your knowledge of the regions you're in, or the cities, the communities you're in, what you're hearing on the ground. And the goal here is really to come up with a list of where we think we should focus efforts and move projects and funds to really have that greatest impact. And as part of this, we also welcome you lifting up other initiatives that you are aware of in this space that are working, because I think part of this, part of our goal here is to identify all the great things that are happening already in Alaska and thinking about, are there ways to scale that or grow that? So again, for the next 20 minutes, we'll go into our breakouts. These will be our focus discussion questions. And we will start sorting you into each room. We can get that going in the background, and we'll be called back to this room in about 20 minutes or so. So you'll see yourself kind of being zoomed out, and then at the end of 20 minutes, you'll be zoomed back into this big room.
We'll see you guys over there. Oh,
We are back. So we had a great discussion today. Our group was very engaged. Through a lot of issues around, hey, Linda, that doesn't fly with me. So kind of some of our takeaways were really looking at developing expertise across the team. So how do we build in that expertise across our APPs, across our MAs, everyone in that team, in terms of subspecialty care in rural Alaska? How do we allow patients to stay in their community as long as it's appropriate for that subspecialty care? We talked about different models on how we would train for that. So online training, we talked about hybrid training, we talked about how do we get subspecialty care and education into places like Prince of Wales. We heard from Prince of Wales where, yes, you can get somebody to the island, but then there's 15 other communities that you need to get out to. So the logistic challenge of that is, not insurmountable, but definitely something that we need to tackle as we talk about education and subspecialty care. We talked about places like Kotzebue having, areas where they have specialty care, and they've developed IDD homes. They've done a lot of building their infrastructure, but still limited for like in-home care. How do we build that in? How do we get the workforce to those areas that need it? We did talk a little bit about compacting in terms of subspecialty care, and wanted to include other things like therapists in there for our mental health workforce, And could that help us build our subspecialty care even remotely? That could be helpful. And utilizing, EMS paramedicine came up again. How do we use that, especially around an example we talked about again today with head injuries or kind of frontline care? How do we bridge that into our subspecialty care? How do we utilize that when patients come back into community? So we had a great discussion. I think there's a lot of opportunity to bridge and to expand subspecialty care. I think it looks really different in different areas of the state. And I think if we continue to strategize on different tactics and make it a multi-pronged approach, I think there's a way that we can definitely improve subspecialty care. So over to you.
Yeah, thanks. So team one, nice job, rocked it. Appreciate the chat, shout outs in the chat. Interesting conversation. So a lot about recruitment. It's hard to talk about healthcare access without talking about providers. And so really important with some, interesting and good solutions. And we kind of talked about that space for a bit, including residency and stipends. I thought a really interesting and important conversation to raise up on when people do need to move into town, the importance of escorts, housing, time paid, flexibility with hotels, and so it isn't just like, can I get a subspecialist to consult remotely? But when I do have an appointment for them to go into a region, how hard that can be and why people often forego subspecialty care even when it's there because of the transportation logistics. Conversations again about data. What does that look like? Conversations about school and early intervention and potentially able to connect, to build off of Dr. Ireland's example of cardiovascular. How can that be done for, asthma and allergies and dermatology and other spaces, psychiatry and moving upstream? But I thought that the really where kind of the conversation ended was a really important thing that I wanted to highlight as we're leaving. And it's like, what's the right mix? And so just because we're highlighting this is the national average for primary care versus subspecialty care, that is likely not the right mix for Alaska. And we really want to highlight that what we're putting up on these slides isn't to say this is the goal that we should be reaching. I think Alaska is leading the rest of the country in a lot of things, and we should just blow everyone out of the water with the rural health transformation and find the right mix that really makes people healthy and well and are utilizing our dollars as well as possible. So I just wanted to highlight the fact that the goal isn't to say to become the national average. The goal is to do what's right for Alaskans and to be able to move upstream. And I guess I will just challenge this group as we're closing out. What do you think that metric looks like? How do we measure that? How do we make sure that we've got the right metrics to think about what this looks like at the end of the day? So with that and group one, I am going to turn it over to Trisha to close us out.
Great. Thank you so much. It's been such a pleasure to have everyone here to have these discussions. I want to encourage you to join us for our next events coming up at 12:30. It is Strengthening Workforce, and then Spark Technology is tomorrow. Quick apology to those that were struggling with the breakout rooms. I think what we're finding out is if you were forwarded the invite, that doesn't work as well. Please try to register in advance for these next sessions, and then try to join through the Zoom app and not the browser. So hopefully that will help people out in the future. And next slide, please. If you want more information about the Rural Health Transformation Program, please scan this QR code to get to our website, and I hope to see you all this afternoon. Thank you so much.